Understanding Genetic Risk for Ovarian Cancer. Speaker, Kristin K. Zorn, MD. Medical Director of the Magee High Risk Ovarian Cancer Program, Division of Gynecologic Oncology. Assistant Professor, University of Pittsburgh. NOCC, Medical Advisory and Scientific Board.
So I always like to help you guys get oriented first by putting numbers into perspective, and a lot of times that's what I'm spending time with women that we're meeting in the high-risk clinic, is to help them put relative risks into perspective. And so we're going to run through some numbers here that hopefully will help you get a sense of that. Every year the government puts together their estimated numbers of new cases of cancers for both men and women, and so they give us the top 10. Just to help you have an overall sense, breast cancer is the #1 most common cancer in the United States, with almost 200,000 cases. So, and among the gynecologic cancers, uterine cancer or endometrial cancer is actually the most common at 40,000 a year. And then ovarian cancer drops down, and it's about 20,000 cases a year, so roughly half as common as uterine cancer. But now if we roll over and think about deaths from cancer, not just new cancer cases that are diagnosed, you can go ahead and advance. Now breast has dropped down to #2. Why does that happen? Because generally we find breast cancer while it's early in stage and at its most treatable and curable. In our case now, ovary, you can hit the next slide. Yep. And the next one, ovary advances over endometrial cancer now, with almost 16,000 deaths a year, because unfortunately we tend to find ovarian cancer when it's more advanced. The most common stage to be diagnosed at is stage 3C, and so that means that we have a harder time treating and curing ovarian cancer than we do breast cancer, or next slide, endometrial cancer, which has now dropped down to less than 8,000 deaths a year. So that gives us a broad perspective on how common cancer cases are. Again, remember with breast and ovarian cancer, we're talking about a whole power of 10 difference there in how common they are. So to try to put this in perspective a little bit more, when we think about the general population in the U.S., about 1 in 70 American women get ovarian cancer in their lifetime. That compares to about 1 in 8 women who get breast cancer in their lifetime. So again, we're seeing that whole power of 10 difference there between those numbers. And for those of you who think better in percentages than you do in fractions, that converts to a roughly 1.5% lifetime risk for getting ovarian cancer, compared to an over 12% chance of getting breast cancer. And this again is in the general population without factoring in other things like family history. So if we do now factor in family history, let's say if we know that a woman has one first-degree family relative, we're going to talk about this in a little bit more in depth, but a first-degree relative means a mom, a sister, or a daughter, someone directly related to her who's had ovarian cancer. Well, that doubles her risk of developing ovarian cancer. Now that sounds awful if I say it that way, but if we think back to our numbers, we're taking a rare cancer, a 1 in 70 lifetime risk, and making it a roughly 1 in 35 lifetime risk, or taking it up to a 3% lifetime chance. So even with a family member who's been affected by ovarian cancer, there's still, you know, a drastically in your favor chance that you wouldn't develop ovarian cancer. And again, to help give a little bit more perspective, if we think about other cancers that are commonly talked about, pancreatic cancer has roughly the same risk as we do for ovarian cancer, and I think we would all agree that pancreatic cancer is a relatively rare cancer, whereas colon cancer is a very common cancer, about a 5% lifetime risk for developing colon cancer just from being an American. And for prostate cancer is actually even more common than breast cancer, about a 15% chance of developing prostate cancer in a man's lifetime in the U.S. So again, I think sometimes it's helpful just to have a sense of how relatively common, or in our case relatively rare, a disease is. So when we now try to think about what causes, where do cancers come from, I think we generally overestimate how much of cancer comes from family history and genetic risk. And so that's one of the things that we work in the high-risk clinic to help correctly assign how likely it is that there's something that's being passed in a family. The vast majority of cancers are actually what we call sporadic cancers, where they are not due to a gene that's being passed in the family. It's really only a very small percentage of cancers cancers, about 10% that are truly hereditary, where you are inheriting a mutation from one of your parents that is making you more prone to develop that type of cancer. Now, there are some cancers that are what we call familial, which means that there is a history in the family of the cancer, but there's not a direct genetic link. This, I think, is one of the active areas of research to try to understand familial links better when they're not truly prescribed as hereditary, because there's not a specific mutation that's causing it. It may be that we inherit certain tendencies from our parents, i.e. the way we process nutrients in our diet, for example, that may make us more prone to developing a cancer, but it's not the same as inheriting a mutation that directly causes the cancer. So when we're talking about the hereditary causes of ovarian cancer, we're basically talking about BRCA1 and BRCA2. So these are two genes that are what we call tumor suppressor genes. And the best way to think about this, when we think about cancer genes, there's two broad classes. One is oncogenes. These are cancers that, these are genes that are actually what we can think of as an accelerator, hitting the accelerator in the car that causes cell growth and division to speed up. Tumor suppressor genes are the brakes that we're supposed to inherit that keep cell growth and division from getting out of control. And if you lose the brakes, then cell growth goes on uninhibited. So BRCA1 and 2 are both examples of tumor suppressor genes, and they are inherited from the parents, but interestingly enough, they increase the risk of cancer to develop in adulthood. There are a number of other cancer syndromes that are associated with increased risk of childhood cancer, but BRCA1 and 2 help to really redefine the field of cancer genetic counseling, because it's associated with increased risk in adulthood. And so there's a whole series of questions that come from that we'll address as we move through the talk here. There are other sites that are associated with BRCA1 and 2 mutations. We commonly focus on breast and ovarian cancer because they're the most common, but you can see increased risk of prostate cancer, pancreatic cancer, melanoma, and male breast cancer, not just female breast cancer. So when I talk about the gynecologic cancer risk that comes from BRCA1 and 2 mutations, I'm talking about risk to the ovary, the fallopian tube, and the peritoneum. The ovary and fallopian tube, I think most people grasp. The peritoneum is the internal skin or the internal lining of the abdomen. And the reason why we think it develops a cancer that looks like and acts like and is treated just like ovarian cancer is because all three of these sites tend to grow from the same tissue with embryology. And so we think that's why they're prone to develop such similar cancers in adulthood. And with a BRCA1 mutation, the lifetime risk for developing one of those three cancers is about 30 to 40%. So obviously drastically increased over that baseline population risk that we talked about of 1.5%. With BRCA2, the risk for gynecologic cancers is slightly lower, about 13 to 20%, but still obviously significantly increased over that baseline. And just to keep this all in perspective, the risk of breast cancer with either of the mutations, BRCA1 or 2, is 60 to 80% in a woman's lifetime. So the breast cancer risk is actually double the risk of ovarian cancer with BRCA mutations. They are inherited in what's called an autosomal dominant fashion. I promise I'm not trying to take you back to high school biology here, but I'm making some important points when I use this terminology. So as you can see in the diagram, you have a father and a mother. If we're looking on the little diagrams to the side there are showing a chromosome, and the white box is showing a gene that's mutated. So the father is affected by the mutation. His other copy of that gene is normal, and the mom's copies of those genes are both normal. But because it's autosomal dominant, a parent of either sex can pass this on to a child of either sex. And that's a 50-50 chance. So this couple happens to have 4 children in order to make our math as simplified as possible. And they have 2 boys and 2 girls. And the boy here on the far left has inherited the mutation, but you can also see that the girl on the far right has inherited the mutation. So a male parent has passed it on to a male child and a female child, while 2 other children are unaffected, and they followed the law, the Mendelian laws perfectly, and had a 50-50 split. Where that's important for this syndrome, I think, is that it's very easy to focus on the mom's history and the mom's side of the family because we're talking about breast and ovarian cancer, okay? As it turns out, the dad's family history is just as important and can't be overlooked. So even though dad obviously isn't going to get ovarian cancer, he may get male breast cancer. But even if he's unaffected by cancer, his female relatives may be really telling a story that helps to explain an ovarian and breast cancer pattern in the rest of the family. So we can't forget about dad's side of the family is the ultimate point of this. And to get back to that point I made earlier about types of relatives, when you meet with a genetic counselor, this is really the first step of what they try to help you do. This is called a family tree or a pedigree, and they're basically diagramming out the family tree. And if we start here at the bottom in the middle, that arrow is pointing to someone called the proband. That's the patient who comes in to get counseling. And so from the proband we diagram out. That's her husband and her child, and then her sister and her brother, and then her father and her mother. All of those people are first-degree relatives. So children, siblings, and parents are first-degree relatives. And then when we move back further in the generations to the paternal and the maternal grandparents, as well as the aunts and uncles, those are now second-degree relatives. They're one step further removed. And then here on the far right, the children of the uncle, now the first cousin of the proband, is a third-degree relative. And so this is important because it's sort of degrees of relatedness. And again, since we're talking about something that's autosomal dominant, it helps to give us a sense of the likelihood of inheriting something if there's a similar pattern of disease between different family members. So when we try to define who's at high risk, obviously we know if someone's already been tested and we know they carry a BRCA1 or 2 mutation, they're at the risk that we talked about a couple of slides ago. But when we're just looking at family histories where no one's been tested yet, we don't know about mutation status, the pattern that we're looking for to suggest a familial component is an early age of onset of the cancer. So typically before menopause, if you're thinking about for breast and ovarian cancer, that's a good cutoff to think of for early. The presence of bilateral breast cancer, which means that both breasts have been affected by separate cancer diagnoses. More than one primary cancer, meaning that the same person developed two different types of cancer. For example, a woman who developed breast and ovarian cancer, maybe a man in the family developed pancreatic and male breast cancer. So more than one cancer in an individual starts to suggest a hereditary predisposition. And then the presence of male breast cancer simply because it's so rare. Although actually if we look at male breast cancer as its own separate field, the majority of male breast cancer is still not associated with an inherited gene, okay? So even something that's that rare of a situation is still not associated with a BRCA mutation in most cases. And then Ashkenazi Jewish ancestry is important to consider. We may well have folks who are of this descent in the audience. It's actually fairly common in Pittsburgh because Ashkenazi Jewish simply refers to the fact that you originally came from Eastern Europe or your family originally came from Eastern Europe. There's a lot of misconceptions about this. Some people think that it tracks with, say, an Orthodox sect or something like that of Judaism, but it's simply that the original ancestry came from Eastern Europe. So in a place like Pittsburgh, where we have a lot of immigrants who came in the past centuries, then you can see how common it is. Actually, most American Jews are of Ashkenazi Jewish descent. So it's actually more likely that you are of Ashkenazi descent than that you are not as an American Jew. And family history gets complicated, so we have some caveats that we have to keep in mind about this. About 20 to 30% of women who have a breast cancer diagnosis have at least one family member who has had the disease as well, but only 5 to 10% of them have a hereditary syndrome. And this is, again, is just sort of the law of averages. When you have a common cancer like breast cancer is, it's more likely that you'll see more than one case in a family. There are other syndromes that can involve breast and or gynecologic cancer that occasionally we need to figure out. The main thing that we worry about in the high-risk ovary clinic is clarifying families that may have HMPCC or Lynch syndrome. That is associated with colon, endometrial, and ovarian cancer. Colon and endometrial are the dominant cancers there. Ovarian is much less common. There are some folks who think that breast cancer can be present in Lynch syndrome, but most people do not. Most people think that this really is the defining cancers of the Lynch syndrome, with the possible addition of some urologic tumors, kidney and ureteral tumors. But typically, breast cancer is not part of that syndrome. There are other breast cancer syndromes like Li-Fraumeni and Cowden syndrome that are relatively uncommon. But again, I'm not saying that we all need to be particularly well versed in this. This is why we have genetic counselors to help us look at family pedigrees and start to think about these really rare situations that may be going on in a particular family. Okay. So the other things that we have to keep in mind, I'm going to use some doctor terms here, genes that can have variable expressivity and incomplete penetrance. And what that means is that the same gene mutation can appear differently in different families and in different members of the same family. So just the fact that, for example, two sisters have the same BRCA mutation, one may develop breast cancer at a much younger age, one may never develop cancer, one may develop ovarian cancer instead of breast cancer. So the genes can behave differently in different people for reasons that we don't completely understand. So you can't in a family assume that because somebody doesn't have cancer that they're unaffected. Even though the likelihood is that they would develop cancer if they carried a mutation, you can't assume that they don't simply because the cancer hasn't shown up yet. There's also a lot of families that have limited knowledge of family history. In the past, it was quite common not to discuss cancer. It was considered a taboo subject, and it was really only in the 1970s, especially when Betty Ford talked openly about her breast cancer diagnosis, that it became much more common to talk openly about this. So many families don't have a good sense of what their grandparents and their great-grandparents died of. And we particularly struggle in GYN cancer with what I call the cancer down there phenomenon, where, you know, she had a cancer down here. Well, that doesn't help me so much because that could have been her uterus, her colon, her cervix, her ovaries, her fallopian tube. You know, it's kind of endless what could have happened down there. So just knowing that it was below the waist doesn't really solve the problem for us, especially because that could even be a cancer that started, for example, in the breast or the lung and then spread down to the ovaries or to the colon or somewhere else. So we sometimes, even if they know that there's a cancer, don't have great insight into where the cancer actually started. We also increasingly recognize that there's some families that are what we call a small kindred. There's just few people in the family, or particularly if there's few women in the family. And that's actually been formally defined now by one of my colleagues that I have worked with, who said that any family that has two or fewer first or second degree female relatives who are over 45 on both the maternal and paternal side has what we call a truncated or a limited kindred, which means that you have to have enough women get old enough to develop cancer to know whether there's a predisposition. And so it's not uncommon that you'll see a family, maybe it's a pretty big family tree, but it's a lot of guys and there's relatively few women. And so those families are just going to be less informative to us to really discern if something that's primarily affecting women is going on. So the role of the genetic counselors, I've mentioned a couple of times now, genetic counselors are a big piece of this puzzle. They're an integral part of our high-risk clinic, and there's a reason for that. These are folks who have a master's degree specifically in genetics and understanding how to help people understand their genetic risk and how to manage it. So the first step when you meet with a genetic counselor is to do what's called a risk assessment for hereditary conditions. Now, obviously, we're focusing on cancer here, and our genetic counselors are specifically cancer-oriented genetic counselors, but we also have a whole group of genetic counselors that help focus on prenatal diagnosis and early childhood diseases that don't have to do with cancer. So, for example, things like Tay-Sachs and other diseases that can run in families that aren't specifically cancer-related. So we're obviously going to focus on the cancer piece of this. They help people understand when testing is available and whether that's the right decision for them. So they help to get informed consent for genetic testing, and then they help to interpret the results, because unfortunately sometimes this is much more nuanced than simply a positive or a negative. And then they help to educate the patient, the patient's family, and the patient's caregivers, because sometimes we're talking about really rare situations where maybe caregivers need a little bit of education to understand what's the best thing to do for that. So I was worried this wouldn't project all that well, and I'm fairly correct in that. So, so let me just talk you through it. This is another one of those pedigrees that we talked about a few minutes ago, and we're going to talk through two cases to try to get a little bit of a sense of what it is that the genetic counselor is doing. So here we have someone who has a premenopausal breast cancer. The black dots mean they're affected by the cancer that we're talking about, okay? So circles mean it's a woman. The black dot means she's affected by cancer, and what you can't read down here is it says that she had breast cancer at 48. We see her So this is her parents. So this is her aunt here that's also affected by breast cancer at age 48. So a second premenopausal breast cancer. But that's it cancer-wise in this family. And so what we can tell from this pedigree is that we have 2 cases of early onset breast cancer. Again, we're using menopause as the definition of early onset. But they're related through an unaffected woman. So this woman's mother is unaffected, and you can't read this, but it says that she's 78 years old. So she's alive. She doesn't have a line through her. You get a line through you if you're dead. She's alive, and she's at 78 and hasn't developed breast or ovarian cancer yet. So that's actually good news and helps to point away from a hereditary syndrome. There's also a lot of women in this family, right? She has this whole slew of aunts who all are alive and have not developed breast cancer. So that again is pointing away from a hereditary syndrome. And we actually have computer programs that help us to plug all of this in, and when you crank this family into that computer program, it only comes out with about a 1% chance of carrying a BRCA mutation in this family. So even though we have 2 early onset breast cancers, we have a lot of other things that kind of point away from it. So let's compare that to this family. Again, we have a person here who has breast cancer at age 48, so just like our patient in the last case, but now she's related through a mother who was unaffected by cancer at 78, the same age as our last mother, but this woman had her tubes and ovaries removed at age 35. So she had what we call a BSO, that's the technical name for removal of tubes and ovaries, well before menopause, and so could have potentially prevented an ovarian cancer from developing because she did that. Probably had it done for benign reasons. It also would have decreased her risk for breast cancer, because if you have your ovaries removed premenopausally, you have about a 50% risk reduction for breast cancer. And then in this family, now we have another breast cancer diagnosis at age 47 in a great aunt. And then we have an ovarian cancer diagnosis at age 45. So this is where the families start to differ. We now have an unaffected mother, yes, but we have potential mitigating circumstances in that mom. And then we have other suspicious diseases, breast and ovarian, in the further back generations. And so when we take all of that into consideration, and again, in this family, we don't have those multiple aunts who are unaffected. We have a smaller family with fewer female relatives. Their risk in this family comes out to 50% for carrying a BRCA mutation when you plug them into the algorithms. And so both of these women go to see the genetic counselor and ultimately decide to undergo genetic testing. And what we're going to get back from that genetic testing is a positive result in the sense that a mutation is found. And what that means is that there is the increased risk that we talked about from my earlier slides, and we have guidelines to help people manage that risk based on that diagnosis. That's actually the most informative result, is if it comes back positive. We know what to do with that, okay? The harder results are these last 2, a negative result, which means that they haven't found a mutation. And that's a little bit more complicated. Obviously, they don't have the most commonly known mutations of BRCA1 and 2, so it is somewhat reassuring. We see a reduced likelihood of an inherited cancer predisposition, but we can't completely rule it out. There's 3 possible scenarios there. One is that the family really doesn't have a mutation and that this is a true negative. The other is that the family does have a mutation and we just don't know how to test for it yet. And the third is that our patient just didn't inherit a mutation that does exist in the family, because again, each person only has a 50-50 chance of inheriting a mutation if it existed in their parents. And so that's when it gets tricky. Sometimes testing multiple family members can help to figure out situations like this, but it gets complicated. And so usually for those families, we fall back on looking at the overall pattern of family history to help make specific management guidelines for that patient. And then I think the most complicated situation is when what's called a variant is found. And this is very commonly interpreted by patients as meaning, oh, I have a mutation. But really what it means, our genes, again, are part of our DNA. That's how our DNA is organized. And if you think about our cells dividing, they basically have to copy over their DNA. And there's a whole string of letters that make up our DNA, and there's typos that happen. You know, our genes are just prone to error, just like all of us are when we're typing. And most typos are completely benign and don't have a negative consequence from them. And that's what a variant is. It's a typo that doesn't mean anything. But it's right now we're still learning in the process of understanding the genetic code, and we don't always know when those typos are important or when they're not. If they're important, if they cause negative negative consequences, that's when it gets classified as a mutation, like BRCA1 and 2. But there's usually a time period where we have to keep collecting additional data about that specific variant to see ultimately, is it tracking with disease, or can we prove that now the gene's outcome, the protein that comes from that gene, is really being negatively affected by it. So there's some families that are in a little bit of limbo because they've been diagnosed with a variant and we don't yet know whether that's deleterious or harmful or not. So in our case, both of these women did not have a BRCA mutation. So let's talk through how we're going to interpret that. So back to case 1, this was the lower risk family for carrying a BRCA mutation. We feel comfortable that we've ruled out the majority of the chance that the patient has a BRCA1 or 2 mutation. And the family's overall history is most suggestive of sporadic cancer. Again, sporadic cancer is by far the most common type of cancer. And so we feel more comfortable that this family likely is falling into that picture. In addition, because it's only breast, I don't have any suggestion of a particularly increased risk for ovarian cancer in the family. So we don't have to recommend specific interventions because of an ovarian cancer risk. But there still can be an increased risk for breast cancer in the family, more probably from that familial type of cancer as a possibility than because there's an inherited gene that's specifically being found. And for our case 2 family, we're still a little bit worried about this family, right? Because they had a more suspicious pattern of breast and also combined with ovarian cancer. And so when we can't find a BRCA mutation to explain it, we still have to say, based on our experience, that this is a hereditary breast and ovarian cancer family or kindred, and we counsel them based on that, which essentially falls in line with some of our BRCA mutation guidelines. So we would talk to this patient and her family members as if they are at continued risk. And just as a little bit of a side note, these are the type of families that it's really important that they stay plugged in and participate in research so that we have specimens available from them as testing improves, so that if we figure out, for example, the so-called BRCA3, the next gene that's found to be associated with ovarian cancer risk, we can come back to families like this and test them to see if there is in fact a mutation there now that we know how to test for it. So there are specific mutations that are the most common. These are called the founder mutations that grouped with Ashkenazi ancestry. What that means is that there was a relatively small population, in this case the Ashkenazi Jews in Eastern Europe, that the mutations first arose by chance in that population, these 3 mutations, and then because it was a small community that tended to marry within itself rather than intermarry with other populations, the mutations gradually became more and more concentrated and then traveled with the Ashkenazi Jewish population as they moved to other parts of the world, including the U.S. We do also see founder mutations in other populations, as you can imagine, a place like Iceland, where again the population is relatively isolated and not intermarrying and therefore getting a lot of genetic heterogeneity. But there have been other BRCA mutations that have been described that are also founder mutations. They're just much less common than the Ashkenazi founder mutations. And so when we talk about the risk of carrying a BRCA1 or 2 mutation, the general population risks vary widely because the population studied in the literature have varied widely. As you can imagine, it really depends where you're testing, what their genetic makeup, what the lineage is of those folks, where did they come from in the world, as to how common you're going to find BRCA mutations. It can be anywhere from 1 in 300 to 1 in 1,300 for BRCA1 and 1 in 130 to 1 in 1,300 for BRCA2. And now if we move to the Ashkenazi population, it's got about a 2% background frequency. So regardless of family history, without any knowledge about breast or ovarian cancer risk, among Ashkenazi Jewish patients, there's about a 2% chance that there's already a BRCA mutation present. And then it becomes much more common as we add in family history. If there's a family history of breast and ovarian cancer, it can be as high as 50 to 90% that a mutation will be found. And among Ashkenazi Jewish women with breast cancer, it's about 12% of them that carry a BRCA mutation. So sometimes people have specific questions about how the genetic testing works. It's a blood test, so it's a simple blood draw that's then sent off to a company called Myriad. You may have heard about this in the news because Myriad has a patent on the testing for BRCA1 and 2 mutations, and that patent is being contested, and it's probably going to go all the way to the Supreme Court in sometime in a couple or 3 years, we may have an answer from the Supreme Court about whether it's considered constitutional to patent testing of the human genome. So it's a huge legal question. Right now the patent stands. So in the U.S., the only way to get genetic testing for BRCA mutations is through Myriad. Other parts of the world, the patent is not in effect, and so there's other labs that are doing the testing. And that's probably why we also have a very expensive testing, because there's a monopoly on the testing right now. The baseline test for BRCA1 and 2 basically sequences the BRCA1 and 2 genes and looks for what's called a rearrangement, which is one of the confusing types of mutations that it's hard for full sequencing to pick up. That costs about $3,300 to do full sequencing. An additional test became available a couple of years ago called BART, which looks for other rearrangements that they realized were showing up relatively frequently. So that's an additional $700. Eventually, BART is going to be an automatic part of the first step. Myriad had said it would be within a year, about a year ago. So I still haven't heard that it's automatically going to become part of it, but that will happen. Unfortunately, that may well mean that there's also going to be a cost increase, but that would ultimately be a good thing, because obviously we want to test everybody. When we're doing testing, we want it to be for all of the mutations that we know of currently. There are some families that were in the process of going back and testing for BART if they had BRCA mutation testing before BART was available. When we're dealing with an Ashkenazi Jewish family, we often start, though, with a less expensive panel that looks specifically for those 3 founder mutations, because it's less expensive to do that, and that's the most likely mutation to be present in that family. Now, if we do the Ashkenazi Jewish panel and we find the mutation, great, we're done. If we don't find a mutation, then we do need to go back and do the full testing, because it's possible to be Ashkenazi Jewish, not have an Ashkenazi Jewish founder mutation, but still have another type of mutation in BRCA1 or 2. And so it gets a little complicated for those families, but we generally do the less expensive $500 test as the first step. Now, what's really helpful is if we identify the first person in the family who has a mutation, because after that, everybody else in the family only has to be tested for that specific mutation, and that's much less expensive. So it brings it down from over $3,000 to a little bit less than $500. And so that's why our strategies are to try to find that first person in the family who's most likely to carry the mutation. The U.S. Preventive Services Task Force makes recommendations. Many of you are probably aware of some controversial recommendations about mammograms in women from 40 to 50 that have been discussed for the past couple of years. They've also looked at this question of who should be referred and undergo genetic testing. And as you can see, it's completely stratified on whether there's Ashkenazi Jewish descent or not. FDR refers to first degree relative. Breast cancer is BC, ovarian cancer is OC, and then SDR is second degree relative. And so you have to have there's a little bit of a higher threshold to do testing in someone who's not of Ashkenazi Jewish descent than there is for someone with Ashkenazi Jewish descent. So I'm not expecting you to absorb all of the details of this, but just to understand this is a really long column, that's a really short column, is sort of what it boils down to. And so when we're talking about who to test in a family, it's very common for someone who's not affected by cancer, but who's worried about their family history to show up as the first person to undergo counseling and to want to undergo testing. But really what we often have to say is, you know what, we need to go back to your mom, your aunt, your grandmother, your cousin, whoever it is that's already affected by either breast or ovarian cancer, because they're the best person to test. They're the most likely person to carry a mutation if it's present in the family, and they're the most likely to have insurance company coverage for testing. There's a bizarre situation in the U.S. where it's more common to cover the testing if you've already developed a cancer than in a preventative setting. Although the people who benefit the most from the testing, we could argue, are the people who are trying to prevent cancer rather than the people who've already been diagnosed with it. But in general, we don't do a good job of covering preventive services in our insurance system right now. So hopefully that'll change. But currently, it's very common for people who are not affected by cancer to get an answer back from their insurance company that they won't pay for the testing. It may also impact the care of the person who's already been diagnosed with a cancer. So if she's a breast cancer patient, she may decide, instead of having breast conserving therapy like a lumpectomy, to go ahead and have mastectomy because she's at such a risk for another breast cancer to develop. She may choose to undergo a BSO, which is again the removal of the tubes and ovaries if there's a BRCA mutation present. And we have some therapies that seem to be very helpful for people who carry BRCA mutations called PARP inhibitors. And so it may actually affect what chemotherapy choices are made for a particular patient if there's a mutation present or absent. And then if that person who's affected by cancer is found to have the mutation, again, other people in the family just need to pay a little bit less than $500 to get the specific mutation tested for. And even if that's not covered by insurance, $500 is a lot more affordable than $3,500. That's why this is the strategy that we take with the testing. There is currently no justification for testing children, and the reason for that is that there is no documented cases of breast or ovarian cancer before age 18, since these are diseases of adulthood. And so we prefer for children to reach the age of majority and make a decision for themselves after counseling whether they want to pursue testing or not. It's a very individualized decision. I've seen siblings within the same family. Some of them choose to test, some of them choose not to. So it's a very personal decision. And so we don't make it for them since there's not early onset in childhood of cancer. Again, this is a complicated slide, but I just want you to understand the overall trend. This came from a high-risk clinic that does counseling similar to ours, and they did it first for BRCA1 mutation carriers and then for BRCA2 mutation carriers. We'll see it in the next slide. But the point that they're making is that, yes, we have that lifetime risk of ovarian cancer with the mutation, but it only gradually increases in risk. And so many women are showing up to be counseled in the decade of their 20s or their 30s. So if you look at their current age here, and then across the chart, it's giving you the idea of how likely is it to develop ovarian cancer within the next decade. And it starts very much on the low end. So many women are coming to get counseling from us when they're still in the 1%, 2%, 3% range. And we're trying to make decisions to minimize risk before they get to the 20, 30% range when they're much more likely to be affected by the cancer. So many women who are coming for counseling have some time to think it through and make a thoughtful decision, I think, is the main issue here. And then this is for BRCA2. Again, remember, we had overall a lower risk for ovarian cancer with BRCA2, and so these numbers also are lower as well. Okay? So where do our screening guidelines stand right now? So once we know someone carries a mutation, we want to try to be proactive and either keep them from developing cancer at all or find it at the earliest possible stage when it's the most treatable and curable. The unfortunate truth is that we don't recommend screening in the general population in the U.S., and there's a very good reason for this. It's because CA125 and ultrasound screening are ineffective in the general population. Ovarian cancer risk is so low that we don't do an effective job of picking it up at early stages with screening in the general population. When we look at guidelines for women that we know carry BRCA mutations or who their families that we are calling hereditary breast and ovarian cancer families because we can't define the mutation in them, but their histories are so worrisome. The current recommendations are to use CA125 and ultrasound after age 30. They can be done on an every 6 to 12 month basis, but really that hasn't even been shown to improve survival. It's simply the best that we have right now. We don't have anything better, and we feel like we need to do something in this population, and so that's really where that comes from. There is no proven survival benefit. So if I have a group of mutation carriers who choose to undergo screening with ultrasound and CA125 and a group of mutation carriers who choose not to undergo screening, the ones who are ultimately diagnosed with ovarian cancer, you don't live longer because you were doing screening in this group than in this group. And that's really the benefit, that's the whole point of doing a screening test, is that it ultimately improves survival. So there's a lot of debate over this. I know Dr. Oz just had a big show on this that a lot of you probably saw. And it's not that physicians are, being mean by withholding ultrasound and CA125, it's that they're inappropriate. They haven't proven themselves to be useful. And so that's why we haven't, as a medical community, adopted them uniformly. But we do have some options to help prevention. Actually, this is the most underappreciated chemo prevention that we have, which is birth control pills. There's about a 50% risk reduction for ovarian cancer with the use of birth control pills for 5 years. This has been documented multiple times in many studies. Having ever used birth control pills in your lifetime seems to be as beneficial as currently being on them. So, you know, if you're now in your 40s but you used birth control pills when you were in your 20s, that benefit is still with you. We don't completely understand where this comes from. It may well come more from the progesterone component of birth control pills than from the estrogen component. We do have some studies that suggest that that benefit is also present in women who carry BRCA mutations. And so if I'm counseling a 20-year-old BRCA mutation carriers, this is one of the things that we cover, whether birth control pills are appropriate for her or not. The main downside there is that there's a possibility of a slight increased risk of breast cancer with birth control pill use. Again, probably because of the progesterone component. So it's the progesterone component seems to be helpful from an ovarian standpoint, but possibly harmful from a breast cancer standpoint. Birth control pills have been studied dozens and dozens of times in terms of their breast cancer risk, and it's never been shown to be more than a very slight increased risk. And in BRCA mutation carriers, we have to keep in mind that there's a 60 to 80% lifetime risk of breast cancer. So my personal feeling is that that slight uptick in the risk for breast cancer that may come from birth control pills is probably on the order of a couple of percentage points. So in the general population, that might be an issue when breast cancer is relatively less common if we significantly increase that risk. But when we're talking about somebody who's already at 60 to 80%, if we go to, say, from 60 to 62%, not really making a big difference there, okay? So, and of course we have to factor in what else is going on with the young woman's life. Does she need an effective form of contraception anyway? So all of these factors have to be considered. We have other evidence that some common gynecologic surgeries, so tubal ligation, getting your tubes tied, and having a hysterectomy are both protective against ovarian cancer. About a 30% risk reduction with either of these procedures. We don't completely understand why that is. It may be because we're understanding that there's more and more of a role for the fallopian tube in ovarian cancer, and so this may be cutting off the pathway somewhat between the two environments of the lower genital tract and the higher genital tract, but this seems to also carry over into the high-risk population. I'm not saying that a woman would choose to have her tubes tied or to have a hysterectomy just because she carries a BRCA mutation, but if she already has had to make that decision because of other factors in her life, this offers some reassurance. But unfortunately, ultimately, any of those factors aren't strong enough that we can take that 30 to 40% lifetime risk with BRCA1 and 10 to 30% with BRCA2 and say, you're at such a low risk now that we feel like we're out of the woods. And so what our ultimate recommendation, especially since our screening is not effective for ovarian cancer, is that they go ahead and have their tubes and ovaries surgically removed. Again, that's called a bilateral salpingo-oophorectomy is the technical name. You can see why we abbreviate it as BSO for short. And that's really extremely effective. It's about a 90 to 95% risk reduction for ovarian and fallopian tube cancer. If you'll remember that third cancer, peritoneal cancer that I mentioned, that still has a small risk because we can't completely remove the peritoneum. But in most studies, that's about a 1 to 5% lifetime chance. So we've drastically reduced the risk for ovarian and fallopian tube cancers with doing it. As I mentioned earlier, if a woman is premenopausal and she has her tubes and ovaries removed, that also decreases her risk for breast cancer by about 50%. And that's why if you talk to women who had breast cancer decades ago, actually BSO was a common strategy for management of premenopausal breast cancer because they didn't yet have tamoxifen. Tamoxifen now has taken the place of the BSO in young breast cancer patients because it's essentially blocking the hormone in breast tissue. But before tamoxifen came along, many medical oncologists treating breast cancer patients relied on BSO to help in their therapy. But obviously we have this pretty important side effect of premature menopause, and so that has impacts not just for obvious things like fertility, hot flashes, night sweats, mood swings, libido changes, but also important health issues like early onset of cardiovascular disease and osteoporosis. So one of the questions that I deal with most commonly in working in the high-risk population is helping to determine whether someone is a candidate for hormone replacement after they undergo the BSO? And it's a very complicated question. This is actually just a small subset of the questions that I need to know and have answered about that patient before I can really make that recommendation to her. So we have to consider what her cancer history is already. So if she's already had a hormone receptor and ER/PR positive breast cancer, there's no way that her medical oncologist is ever going to be comfortable with her taking hormone replacement. If she's had a triple negative breast cancer, though, then she might well be a candidate for hormone replacement. And women who have BRCA1 mutations are more likely to get triple negative breast cancers than patients with BRCA2 mutations. We also have to factor in whether a woman wants a hysterectomy or not. You don't have to have a hysterectomy as part of the BRCA mutation situation because there's not an increased risk for cervical or for uterine cancer. Some women choose to because they're already having some other gynecologic issues. If they do have a hysterectomy, it simplifies hormone replacement a little bit because you just need estrogen. You don't need the progesterone component. And if you'll remember, we don't really have a suggestion of increased risk for breast cancer from taking estrogen alone. It's really the progesterone component that's probably the culprit there. So to sort of boil down my counseling to high-risk patients to the lowest, most common scenario, the lowest common denominator, there's no proven efficacy for screening for ovarian cancer. And so I have to return to this over and over again because I can't tell you the number of women who said, I get you, Dr. Zorn, there's no effective screening for ovarian cancer, but I just feel so much better knowing that I don't have ovarian cancer after I get my CA-125 and my ultrasound done. And so I have to revisit with that patient and say that's what I mean when I say ultrasound and CA-125 aren't effective, is that we've had women who get their screening done and 2 months later are diagnosed with ovarian cancer because it's just not effective at picking up ovarian cancer as early as we want it to be. We also have significant issues with false positives from the screening, especially in the young women in their 20s and 30s where the tests are abnormal even though they don't have cancer. And you might say, oh, well, that's okay because then, you know, they do their follow-up, they get a negative result, and they just be relieved that they don't have cancer. But we may have to take out the tubes and ovaries to prove that they don't have cancer. And these are young women who may have wanted additional fertility, who may have wanted to preserve their natural hormone until they were closer to menopause. So false positives do have an impact, especially if doing that surgery of the BSO is now associated with some kind of surgical complication. So it's easy to think that false positives aren't important, but we know as care providers that they really can have devastating consequences. There's potential benefit from birth control pill use for risk reduction for ovarian cancer, but we have to factor in a possible impact on breast cancer risk, whether they've already had a breast cancer that was hormone receptor positive or whether they're only at risk to develop breast cancer and haven't yet. And we also have to keep in mind that ovarian cancer is much more likely to be diagnosed at a higher stage, at stage 3 or higher, than breast cancer is. So when I'm thinking about the breast cancer piece of it, I'm more reassured about managing breast cancer risk because we have mammogram and MRI for high-risk women that do a very effective job at finding breast cancer at stage 1, again, when it's most treatable and curable, where I don't have that same kind of screening strategy that's effective for ovarian cancer. So if I have my druthers, I'd really want to focus on ovarian cancer risk reduction with my birth control pill use and accept a potential slight increase in breast cancer risk because I can do more about that breast cancer risk than I can the ovarian cancer risk. We do recommend ultrasound and CA-125 that can be considered after age 30. My personal recommendation is that it's done annually, once a year, rather than every 6 months. For those of you who are familiar with statistics, if you have a test that has a high false positive and a high false that has both problems with false positives and false negatives, doing a test that performs poorly statistically, doing it more often doesn't help it do better. It actually only does worse. And so that's why I prefer the annual. I do have patients who are already in the habit and the practice of doing it every 6 months, and we can continue that if that's their preference. But again, we just have to remind you that doing a poor test more often doesn't mean that you're getting more reassurance. And so that's why with ovarian cancer we really have to keep coming back to strong consideration of the prophylactic surgery after age 35 or once childbearing is complete. The idea about 35 is that it gets the tubes and ovaries out before we typically see that risk for ovarian cancer start to increase, if you remember that chart that we looked at. But it still allows women to have their ovaries to get their natural hormone both for fertility purposes and to help with the other things we talked about, hot flashes, night sweats, osteoporosis and heart disease. So most women are in the age range of 35 to 40 when they're starting to make this decision. And I think this again compares to the breast cancer situation. Women can certainly consider prophylactic mastectomy for managing their breast cancer risk with BRCA1 and 2. But they also have the option to continue with screening instead, and that's because the screening is better for breast cancer. And so we have to stress BSO much more heavily than we have to stress mastectomy, because I know that I can impact survival by doing BSO where I can't be as confident that we impact survival by doing the mastectomy over simple screening, since mammogram and MRI are pretty darn good. And I just wanted to give you a little bit of a sense of what we're doing here in Pittsburgh. We have a very active high-risk clinic, as hopefully you can tell from the talk. We have some brochures at the back of the room about both clinics if you're interested in knowing more about it. Out of that clinic, I created what's called the Cancer Family Registry. So we're following patients, their family members, collecting their family histories, specimens like blood and urine, and if they go to the operating room with us, specimens from their surgeries, to try to create a pool of specimens that our researchers can learn from. We're working to develop better imaging techniques to identify breast cancer as early as possible. Dr. Zulli and her colleagues, you may have seen a story in the Post-Gazette earlier this week talking about that. We've contributed a large number of patients to that study from the high-risk clinic, where I'm personally doing work in the lab looking at what's called proteomics, or protein markers that may help us predict who in the families is more at risk to develop breast and ovarian cancer and at what age, so that we can try to be a little more nuanced in our recommendations rather than simply saying you got to have your ovaries out after 35. And we're also heavily involved in some of these new therapies for BRCA mutated cancers. So we've been one of the centers for PARP inhibitor trials. We actually have the largest group of phase 1 trials in the country that are ongoing with PARP inhibitors, and some of you in the room may have participated in those. So those are done. We've had one trial here at Magee for ovarian cancer. They also have trials at Hillman that are ongoing for breast, ovarian, and other cancers. So we play a big role in that. And lastly, I can't emphasize enough the importance of genetic counselors. As you may have realized, I've referred to them multiple times. We have a great team of genetic counselors that work both at Hillman and Magee. The same counselors are at both places. They're also present with me when I'm in the high-risk clinic, which means one Friday a month. They also see patients individually, so maybe you don't need the high-risk clinic in terms of my counseling because you've already had an ovarian cancer diagnosis, but you want to know about genetic testing for yourself and for your family, or maybe you're someone who's affected by cancer in your family. You can always start with the genetic counselors. This is their phone number. Again, you can also reach them through the brochures that are at the back of the room. I can't emphasize this enough. There's a large campaign by Myriad to encourage primary care physicians, general OBGYNs, oncologists to order genetic testing on their own. I've worked in this field, it's been the focus of my career for about 5 years now. I have never personally ordered genetic testing from Myriad. I've probably had more patients tested than almost any other physician in Pittsburgh, but I don't order the test myself. It always goes to the genetic counselors. I always have people meet with them first. They perform an invaluable service of really providing a lot of information to patients and their families, making sure that insurance covers the test, or if they don't, you understand what the costs are, and then helping you understand what the test results mean for you and your family. So a lot of physicians, even very smart, very dedicated physicians, don't understand all of these nuances because it's simply not part of what their training was, or it's not part of their area of specialty. So I can't emphasize enough that this needs to go through a genetic counselor. They're very open to having people come in groups. We often have sisters, mothers and daughters, grandmothers and mothers and daughters all coming in at the same time. And that only helps us get a more accurate family history and be able to get multiple people in the family tested. So we actually are at the point now that we're encouraging all women who personally have a diagnosis of ovarian, fallopian tube, or peritoneal cancer to get tested. Part of that is because for many families, again, ovarian cancer is the rarer cancer, so if we test the ovarian cancer patients, we're more likely to pick up a BRCA mutation if it's present than we are if we only test breast cancer patients, because again, breast cancer is so much more common that even in a family that has a BRCA mutation, you may have sporadic breast cancers that aren't associated with the mutation. So if we test the ovarian cancer patients, they may be the best indicators. It's also a rarer cancer, so it's a smaller group of people that need to be tested. And as we're testing more broadly, we're finding families that don't have the super ominous history of multiple young breast and ovarian cancers, but who still have mutations that are present. And so these are some of the families, as I mentioned, that variable expressivity and penetrance. Some of these families that haven't had as terrible a history of breast and ovarian cancer are at times turning up to have mutations. So it's actually recommended now that all folks who have been personally diagnosed with breast, ovarian, and fallopian tube cancer meet with a genetic counselor and consider testing. Especially if you only had the 3-site Ashkenazi Jewish panel, I would recommend the full panel. Which is the full sequencing of BRCA1 and 2. And then some people who are in your shoes did have that full sequencing, but they haven't had BART. So BART is the next piece of it.
That's what you're saying they'll probably include eventually.
And again, the genetic counselor is invaluable here because there's certain tricks about whether we can get Myriad to cover BART or not. If insurance doesn't pay for it automatically, sometimes they're interested enough from sort of an academic point to define families that they're willing to cover the BART. My strong bias is that I want as many families as possible to get testing and to know if they carry mutations, because we have so much that we can do to be proactive. There's my hands, I focus on taking care of ovarian cancer patients day in and day out, and I'd much rather prevent an ovarian cancer than treat one, okay? Because we just don't have a good enough track record at curing ovarian cancer yet. We're hoping to get there, but I can guarantee you I think the biggest inroads we're going to make in survival from an ovarian cancer standpoint is by preventing it, not because we're going to have some dramatic new treatment strategy in the next few years. So you guys are the vanguard to go out and talk to your friends and your family and your colleagues at NOCC and the lady you go to lunch with and the lady you see at the library, and really get the word out about families that you hear these dramatic histories of multiple breast and ovarian cancers, to really encourage them to pursue genetic testing. Yeah. So, right. So I can see what you're saying, that the genetic counselors are, they all have a college degree, and then they all have a special master's degree where they've done 2 years of additional training specifically in genetic counseling. And so they've done the coursework, they've done extensive clinical training. It's not that dissimilar from like the internship that physicians do, where they spend time on the wards learning from more experienced mentors. And so it's really specifically about getting the family history from folks, helping people to understand what their family history means. They'll track down path reports from family members who have been affected by cancer or may have died. They'll track down death certificates to try to help figure out if that cancer down there was colon or breast or ovarian cancer. They will assess insurance coverage for genetic testing. They will appeal to the insurance company if it's not covered to try to get it covered. Then they get the test sent off and then go over the test results with you. So they have an incredible amount of specific expertise exactly in this issue. So there is a little bit of a social work component because they're dealing with families that are very conflicted about deciding whether to undergo testing or not. And maybe, as I mentioned, some of these siblings where some want to test and some don't. So they do have that a little bit of the social work component to their job, but they actually have a much more specialized expertise even beyond that and the genetic piece of it. And so even as well-versed in this area as I am, I still rely on my genetic counselors routinely. So they really they're a very special piece of our system. And, for example, we've had patients who came in for counseling about a possible BRCA mutation where that ended up not being the issue, but maybe there's a Lynch syndrome going on in the family, or even more rarely, but it has come up, there's a Li-Fraumeni syndrome going on in the family. And that's really important that they're helping us to pick up those families. Lynch is a little bit different. We start with testing of a tumor. So if a woman's had endometrial cancer or colon cancer, if a man in the family's had colon cancer or urologic cancer, they actually start by testing the tumor itself for the genes that are abnormal. In Lynch syndrome, they're called mismatch repair genes. Again, they're some of the genes that help to deal with some of these typos in the DNA. And so they start by testing the tumor and then test the blood after they've tested the tumor. So it's a little bit of a different process. And so the genetic counselors, for example, play a big part in, maybe your brother had colon cancer at AGH and you're here over at Magee, and so they help to work with your brother's doctor to get his tumor tested to see the likelihood of whether there's a Lynch syndrome going on. So that's the kind of piece of it that they can help tease out. But we are trying to help increase awareness of Lynch syndrome because it's been very focused on the colon piece of it. If you're a woman with Lynch syndrome, it's actually a 50-50 shot that you'll present with endometrial cancer. So the endometrial cancer is as common as the colon cancer in women with Lynch syndrome. And similarly, those women need to think about prophylactic surgery in their late 30s, early 40s, and to include not just the tubes and ovaries, but also the uterus. So here it is critical that the uterus be removed since we're decreasing risk for endometrial cancer, whereas in BRCA, we don't have that same risk for endometrial cancer, so the uterus can stay if a woman prefers. I wanted to mention, this often comes up, is that people are worried about getting tested because of insurance. They're worried about what it means for their insurability going forward, and young people who aren't affected by cancer are worried about getting insurance. So we have a national law called GINA, the Genetic Non-Discrimination Act, that it makes that illegal for health insurance. So it's illegal for health insurers to deny you coverage because of the presence of a mutation, okay? To my knowledge, I'm not aware of a case of this happening since GINA has been passed. And so it really is quite good protection against health coverage. Now, disability and life insurance is not covered by this. If you think about it, the government really can't regulate that because that's the role of adjusters for disability and health and life insurance, is to factor in the likelihood that you're going to develop a problem. That's how they create their risk pools and assign the rate for your insurance. I will say in practical terms, I've never had a patient who says, oh yeah, my quote changed because of the presence of my BRCA mutation. Most insurance companies just aren't very savvy about hereditary cancer, to be really honest, or if they are, they're already factoring it in based on the presence of who's had what cancer in your family by your family history, and the presence of a mutation or not is not changing that for them. So in practical terms, I can't point to patients that we've cared for that have had disability or life insurance become an issue for them, although there is always that potential. And so I guess the rule there would be to insure young while you're as healthy as possible, and before your family members have developed cancers as they get further into adulthood. So I can't promise that it wouldn't come up for disability and life, but it shouldn't come up for health insurance. If it did come up for health insurance, you'd have grounds for a lawsuit. So much.